Okay. Happy noon, everybody. I hope everybody's doing okay. She said, my name is AJ. I'm a PGY1 pharmacy resident from AZ Health Pharmacy in Palatka, Florida. And I'm presenting on my journal club for the article Safety and Efficacy of Medical Cannabis and Fibromyalgia. Special thanks to my mentors, Dr. Frank and Dr. Bradley, for helping me throughout this process. And for full disclosure, this presentation does not reflect the views of the American College of Clinical Pharmacy in regards to the use of medical cannabis for fibromyalgia. And so for a little background information, fibromyalgia is a syndrome characterized by chronic widespread pain, stiffness, fatigue, sleep disturbances, and cognitive function. And it is more prevalent in women than men in the United States. Management involves a combination of pharmacological and non-pharmacological treatment. And since it's very subjective based on the pain, the severity varies widely amongst the patients. And for patients that do have pain for fibromyalgia, it is expected pain is, and anxiety and depression is expected in half of the patients who are diagnosed with fibromyalgia. And there are several controversies around the diagnosis and management of fibromyalgia syndrome. What I mean by that is there is not a specific specialist who deals with the management of fibromyalgia. They usually refer them over to rheumatologists to handle the diagnosis and the management of fibromyalgia, but there are no specialists who helps with that. In regards to the diagnosis criteria, this study utilized the American College of Rheumatology guidelines. I mentioned a few points right here. So in order to be diagnosed with fibromyalgia, they characterized by widespread pain for more than 3 months in the presence of at least 11 of 18 tender points throughout the body. The widespread pain has an index of 7 or greater, and the symptom severity scale score has to be 5 or greater. And the patient would have to not characterize the pain with any other disorder. It has to be from fibromyalgia itself, not from any other disease state. So it's spread up in 2 different interventions for treatment and management. Non-pharmacological interventions, I'm going to talk about that for a little bit. Definitely reassure the patient that to encourage them to utilize cognitive behavioral therapy, exercise in regards to strength training, and then using complementary and alternative medicines. So what I mean by that is complementary medicine is characterized as Tai Chi, acupuncture, and music. In regards to pharmacological interventions, first-line therapy is recommended to use antidepressants or duloxetine or amitriptyline. And then next is the anti-epileptic drugs, opioids, and NSAIDs are not considered useful for the treatment of fibromyalgia. And as this study will explore, can medicinal cannabis be utilized for pharmacological interventions for fibromyalgia? So getting to medicinal cannabis in general. So cannabis products are made up of 2 major active components, THC and CBD, tetrahydrocannabidiol and cannabidiol. So THC is considered the psychoactive component, which affects the pain, appetite, orientation in the receptors, CBD receptors. And then CBD is the physical component, which affects and it has analgesic properties, anti-inflammatory, and anti-anxiety properties. The THC and CBD psychoactive effect are proportional to the THC concentrations. So basically, as the THC concentrations increase, you will have more of the psychoactive components, which is the pain, appetite, orientation. And then as the CBD proportions increase, you'll have more of the physical components, which is the analgesic, anti-inflammatory, and anti-anxiety. So in regards to fibromyalgia, our goal is to find a balance where you have a good amount of CBD to properly treat the fibromyalgia, but at the same time, not have too much of the psychoactive components, which will affect the patient's mental capabilities. So getting into the introduction of my journal club, so the study objective was to investigate the characteristics, safety, and effectiveness of medical cannabis therapy for fibromyalgia. In regards to the study population, notice that the patients were actually from Israel. So majority of the patients were from Israel. All the patients that were studied in the trial were from Israel, and it was required approval from the Israel Medical Cannabis Agency. The study was approved by the Soroka University Medical Center in Beersheba, Israel, and the cannabis was prescribed to patients from one of 8 specified medical cannabis providers. And so they set up a monthly dose by the IMCA, and it's based on the clinical indication as well. So this study was a prospective observational study with a 6-month follow-up. In the analysis, they collected data from patients with a diagnosis of fibromyalgia who initiate treatment with the medical cannabis. Now, the patients were referred to cannabis treatment. They were referred by a primary care doctor or a rheumatologist. And basically what they did was they did a gradual titration. They had a set dose, a low dose for the patients, and then gradually titrated until it reached therapeutic effect. So you may wonder, what is the therapeutic effect? So it's very subjective in nature. So they gave the patients a survey after 6 months. They gave a patient a survey, and then they followed up in 6 months to assess how the patients described how well the cannabis affected their fibromyalgia symptoms. And so it was very subjective in nature. So they considered the therapeutic effect based off of moderate intensity improvement in their symptoms or greater. So, or better, so same as the moderate intensity, moderate therapy improvement, or greater than that. So for patient demographics, 367 started treatment. Pay attention to the age groups. So majority were between 40 to 60 years of age for 9.3%. Majority were female, 82%. And the strains used. So in the study, they separated based off of oil and inflorescence. Now, it was required for the patients not to mix the oil and inflorescence, but as you can see, that was not followed. So 12% were not doing as they were instructed, and they had the mixture of oil and inflorescence at 12%. And it was regarded to have oil first and then inflorescence. So inflorescence is considered like cigarette lighting, and then oil is the oil lights for the cannabis. So in regards to the breakdown, furthermore, pay attention to the previous experience with cannabis. 45.2% of people who initiated the treatment had previous exposure with cannabis. Treatment indication for primary fibromyalgia were 77%. So that means that this is the main treatment. It's treated mainly for fibromyalgia. And then fibromyalgia as a second indication for treatment were separated based on cancer, PTSD, and other. So they're primarily using the cannabis for cancer for 9.5% of patients. 6% for patients had PTSD using it as primary therapy, and then other was spread down to 7.4%. This broke down as type of pain, patients who were cigarette smokers, and they also took note of how many patients normally use medications for fibromyalgia, and it spread it into the median, and then who typically use medications in general. So split into who use medications for fibromyalgia, and then the last bullet point, number who used medications in general. In regards to data collection, so as I mentioned before, they did an intake questionnaire for the patients, and it followed up in 6 months. The diagnosis was determined by a board-certified rheumatologist, and they mentioned before they followed the American College of Rheumatology criteria. Throughout the process, they had a certified nurse providing education for the medicinal cannabis use, and they assessed the symptoms after 6 months using the 8-point Likert scale test. And the patients were instructed, as I mentioned before, to increase the dosage gradually until they reached the therapeutic effect, which was subjective in nature. For study outcomes, effectiveness, so primary outcomes was determined by a treatment response. And as I mentioned before, that was patients had to specifically measure if they had improvement in their symptoms, and it was set as, it started as significant deterioration. They had to mark it as moderate deterioration, slight deterioration, no change, slight improvement, moderate improvement, and significant improvement. So patients who wrote on the survey that had moderate improvement or above or greater were considered a treatment success. So that's what the primary outcome measured. Secondary outcome was split into pain intensity, quality of life, and the perception of the general effect of the cannabis. And patients who were lost to follow-up were considered failures. In regards to the safety analysis, they were measuring the frequency of medical cannabis-related side effects and also the change in fibromyalgia symptoms in the 6 months follow-up. Statistical analysis, so the mean was measured with the standard distribution. Median was measured with the interquartile range. So what is the interquartile range? It's, best way I could describe it is, if you set the median, it takes the median of the group above the main median, and then they set the mean from the group below the median. And if you subtract the difference, the difference between the two is considered the interquartile range for the ordinal or continuous variables. For t-tests, they did analysis. They did t-test analysis for the continuous variables with normal distribution, with the Wilcox test otherwise, and the p-value was set at 0.05 or less. It's two-sided, or considered statistically significant. Now for results, 211 patients out of 365 responded after 6 months. And so, as you can see, the first 4 bullets below that were considered those who were not eligible to respond. So 2 of them died, so they're not eligible to respond. 35 were treated less than 6 months. 28 stopped treatment, and then 4 switched suppliers. That leaves 69 who were eligible to respond, but they didn't respond. So 211 responded total after 6 months. Cannabis approved dosage was 670 milligrams at initiation and 1,000 milligrams at 6 months. And so for primary and secondary indication, after 6 months, the median dose was 140 milligrams of the THC dosage. And then for the CBD dosages for primary and secondary indications, the median was 40 for primary and then 28 milligrams for secondary respectively. So as I mentioned before, primary outcomes, 194, which is out of the 239, 81.1% patients responded at least moderate improvement in their condition. For secondary outcomes, 193 reported high level of pain. And so after 6 months follow, only 19 reported similar pain intensity. And then the pain intensity reduced from a median of 9 at baseline to 2 after 6 months, which was statistically significant. The sleep symptoms, 73% reported that they improved, whereas 26% reported that the sleep symptoms disappeared. So, it's considered statistically significant for those who had sleep symptoms that disappeared. And then the depression-related symptoms, 125 reported that they initially had depression-related symptoms, and then it improved in 101 patients, or 80% of the patients, which was statistically significant. So this chart right here simply breaks down the patient demographics for those who were non-responders versus responders. And so as you can see, these were not statistically significant for those who responded versus those who not responded based off of the demographics, regardless of age, sex, their previous cannabis experience, or treatment indication. And then same here, as you can see in the p-value for those with secondary indications, secondary smoking, who were driving cars, or they had episodic pain in years with chronic pain, the p-value was considered non-statistically significant in regards to who responded versus those who didn't respond. And this is solely for patient demographics. So as you can see with this chart, this is after the 6 months follow-up. They had a moderate improvement for the most part and a significant improvement afterward. And this is the chart referring back to what I was mentioning in regards to the results for the primary indication of fibromyalgia. As you can see, for pain intensity, initially, patients rated the pain on a scale of 8 to 9, 90 patients, and then 103 patients reported pain on a scale of 10. And 6 months follow-up, the symptoms have improved to majority of patients having a scale, pain intensity scale of 4 to 5, and 82 patients responded to that at 6 months after treatment. So in regards to the effectiveness analysis, changes in other drug measurements after 6 months of cannabis treatment, these are, I split them down into patients who are on benzos, opioid analgesics, and neuropathic pain drugs. And so the reduction in, or those who reduced it or had stopped the medications or who had no change in the doses between those were non-statistically significant in regards to reducing. So 14%, or sorry, 11.8% stopped benzos and 8% reduced the dose. For opioid analgesics, 14% stopped the dose and 7.9% reduced the dose. And then for neuropathic pain drugs, 14.9% stopped the medication and 8.7% reduced the dose. In regards to safety analysis, the medical cannabis-related adverse effects after 6 months. So these include patients who had ceased cannabis prior to the follow-up. So for the safety analysis, they did include the patients who did stop the cannabis use before the follow-up. And here's the breakdown, and it's split into the adverse effects of dizziness, dry mouth, nausea, and vomiting, hyperactive, psychoactive side effects, drowsiness, increased appetite, weakness, cough, headache, hallucinations, and tremor. And total response of either with 239 patients. Now this what analyzes the quality of life. And so how did the medicinal cannabis improve quality of life? And so this was part of the survey. And as you can see, the results have improved to good after 6 months. 123 patients reported that it was at least good, and then 25 reported that it was very good after the 6 months follow-up, versus 61 who reported very bad and 96 reported who were bad before treatment. So in regards to the treatment response analysis, patients who had the age greater than 60 years or had concerns about medicinal cannabis and spasticity and had previous experience with cannabis were also had statistically significant improvement in their treatment response. And pay attention to the patients who said they had previous experience with cannabis, and we'll get more into that in detail because it's considered now statistically significant. And then those who were, this is the breakdown for patients who consider using medicinal cannabis for secondary treatment for fibromyalgia. So the split, as you can see, those who consider it with concerns about cannabis prior to treatment, with spasticity, with previous experience with cannabis, were not statistically significant. And the age greater than 60 as well. So in conclusion, here's the advantages for the author. At 4 weeks follow-up, there was a significant amount of decrease in pain response, as well as anxiety and improvement in quality of life. There were larger cohort series compared. This was a larger cohort compared to other studies that was utilized. Utilized the assessment of fibromyalgia in an extended follow-up, 6 months. The effect of medical cannabis was studied on every aspect of fibromyalgia. So they took consideration pain, consideration improvement in sleep symptoms, anxiety and depression. So these are the aspects of fibromyalgia that they've analyzed. And as you mentioned before, they said the opioid use decreased or ceased in 22.2% of the users. For the author's limitations, they utilized, it was an observational study, so it could not determine that it was a causality between cannabis and treatment response. 30% of the non-responding rate may have resulted in non-response bias. There was no confirmation of myalgia diagnosis from the American College of Rheumatology, and there was no control group to compare the clinical outcomes of the medical cannabis use. It was simply linked to my causality correlation. There's change in utilization of other drugs for fibromyalgia treatment. It was based on self-reports, so this could risk recall bias. And there's no outcomes for safety of cannabis while driving. There was no assessment based off of that. Here are my advantages. So nearly 50% of the initial patients follow up after 60 months, after 6 months. The majority of the cohort used low dose cannabis at 20 grams or less per month. And then after 6 months, there's a positive treatment response to include patients that follow up in less than the designated 6 months. There's a no dosing strengths given for both THC and CBD components of marijuana. There are no side effects of the medicinal cannabis mentioned in the study, and then examine how cannabis use affected the utilization of other medications. In regards to limitations, it was a very small sample size, and compared to the grand scheme of the nation, there's 30,000 patients utilizing cannabis in Israel compared to those who responded. The studies, what we want to know is what is the study's relevance to the United States? So this was determined in Israel. So I wanted to know, since United States, majority of the patients in the United States are African American who were diagnosed with fibromyalgia, and so I wanted to know how what this study is relevant to the United States since it was done in Israel. There was higher success rates with the previous users. It may be due to the placebo effect. So as I mentioned before, the patients who may have had utilized cannabis in the past may have like may be in their minds that the cannabis have improved their symptoms, and it's because they have had previous effect with they had previous use of the cannabis. So this may be due to a placebo effect. Is titration without a follow-up appropriate? It's a question. No control group in the study for randomized control trials, similar to what the author said was their limitation. There's no established criteria for assessment treatment response. And then 6 months was too long to follow up to address the adverse effects utilized with cannabis. So overall, I believe that going forward, it would be best to conduct randomized controlled trials. So this was a nice start to determine how well medicinal cannabis how it correlates to improvement of fibromyalgia, but we do not have a placebo or current standards of therapy to compare with. So we would like to address like the causality of how medicinal cannabis can treat fibromyalgia. And we would like to have more research determine which type of therapy is more effective between oil and inflorescence. Also consider doing some like superiority trials, as I mentioned before, for FDA-approved therapies for fibromyalgia. And then also, before we even consider utilizing medicinal cannabis, you want to ask yourself, how would this affect the prescribing rate of FDA-approved medications? And also familiarize with the state laws about prescribing cannabis for fibromyalgia. Here are my references. And what questions do you have?
All right, looks like Thomas has a question for you about seeing any benefit due to the CBD component versus the THC component, and whether or not those self-reported improvements, do you think they were probably tied to the THC component, or is there some other mechanism that CBD can elicit on fibromyalgia?
Mm-hmm. Yeah, so that's a good question. The study didn't necessarily break down whether or not it was the CBD or the THC component. What they did was they analyzed. Let me go back to the beginning. So, trying to go back to that. Yeah, so as you see here, they was a decrease in the CBD dosages at, well, it was 140 to begin with at 670 milligrams at initiation, and then increased to 1,000 milligrams per day. But they didn't really necessarily dive into whether was it the THC components or the CBD components that may have improved the symptoms. I think that's something that needs to be further explored as to breaking down the different components and seeing if patients, what was the difference in the THC and CBD components. Did that answer the question?
Yeah, it looks like he said yes. I did have another question for you. In the study, these patients, you mentioned that they were referred either from their PCP or from a rheumatologist. So with us being a lot of us in the primary care setting, how would you speak to physicians about how to identify which patients with fibromyalgia would potentially benefit?
From cannabis?
Yes.
Yes. So that's another thing too, because it seems Israel already had a set educated family practitioners or physicians or pain specialists who who will qualify for treatment for cannabis for fibromyalgia, who wouldn't. So I would say that for here in the United States, we would have to have a educational requirement or have like a set criteria as to who would qualify and who wouldn't. I haven't gotten more deep into how the IMCA qualified patients who qualify for cannabis, but maybe that's something that we can get into, see how do they classify it, and then potentially educate our physicians and rheumatologists here on to classify who would qualify, who would.
Okay. Does anybody else have any questions?
Yes, sir.
Okay. Well, I just really think it's interesting. Obviously, the whole horizon is changing with the use of medical cannabis and CBD use in all of our patients, no matter what specialty we're in. So it's definitely good to know what's out there in terms of safety and efficacy. So thanks, AJ. That was great.
Thank you.
Okay. So yeah, just can everybody make sure and mute their mics just to make sure that there's the decrease in background noise so everyone can hear everyone clearly. And then we'll pass the baton over to Mara. She is our second presenter. She is a PGY2 in AmCare from Penn Medicine in Lancaster, and she is going to be talking to us today about outpatient antimicrobial stewardship. So two very hot topics today, and we'll give the floor to Mara. Thanks.
All right, thank you for the introduction. So like she said, my name's Mara Wilson. I'm currently a PGY2 ambulatory care pharmacy resident at Penn Medicine Lancaster General Health System, which is located in Lancaster, Pennsylvania. And today I'm going to be talking about outpatient antimicrobial stewardship, optimizing patient care via pharmacist-led microbiology review. And I have no conflicts of interest to disclose. Antimicrobial resistance is one of the top 10 largest health threats according to the World Health Organization, and this can occur as a result of improper use of antibiotic therapy. Antimicrobial stewardship programs are implemented in order to reduce inappropriate use of antibiotics, and this is important in the ambulatory care setting because the majority of outpatient antibiotics come from the outpatient setting. And in 2016, at least 30% of outpatient antibiotics were actually deemed to be inappropriate. So as pharmacists, we have an important role in antimicrobial stewardship by evaluating therapy in order to reduce the inappropriate use of antibiotics. The CDC has 4 core elements to provide a framework for antibiotic stewardship for outpatient clinicians and facilities that routinely provide antibiotics in order to measure and improve how they are prescribed by clinicians and used by patients. The first component is commitment, and this is defined as demonstrating dedication to and accountability for optimizing antibiotic prescribing and overall patient safety. Action for policy and practice is implementing at least one policy or practice to improve antibiotic prescribing, then to assess whether it's working and modify as needed. Tracking and reporting is defined as monitoring antibiotic prescribing practices and then offering regular feedback. And then finally, education and expertise is providing educational resources to clinicians and patients on antibiotic prescribing. So overall, improving antibiotic prescribing involves implementing effective strategies to modify prescribing practices in order to align them with evidence-based recommendations. Programs in the inpatient setting on antimicrobial stewardship have been well established compared to those in various outpatient locations. Previous studies on antimicrobial stewardship that primarily focus in the outpatient locations have evaluated clinical support decision tools and culture of follow-up programs, and these have primarily been located in the emergency department and urgent care. These studies have shown the benefits after implementation of tools and have shown an increase in guideline recommended prescribing in the outpatient setting. So then why this study? So this study specifically focused on a pharmacist-led intervention in multiple outpatient locations. It also discusses the role an ambulatory care pharmacist can have by implementing programs in order to improve antibiotic prescribing. And then finally, there's currently limited data on the impact of antimicrobial stewardship programs and interventions on overall patient outcomes. This study was a prospective chart review that occurred in a Veterans Affairs healthcare system in Western New York. The primary focus of this study was looking at the appropriate use of antibiotics. An ID clinical pharmacy specialist was alerted when an oral outpatient antibiotic was ordered, and this order had to be reviewed within 12 hours. They then paid specific attention to antibiotics that were ordered in relation to cultures. And this is what created their antimicrobial stewardship program, which was a daily culture review service. The pharmacist would review cultures and antibiotics daily in order to ensure appropriate coverage of all pathogens, but also to be able to make timely interventions. In addition to evaluating for appropriate coverage, the regimen was also looked at for appropriate dose and duration, as well as patient allergies, any drug interactions, and QTC prolongation. The interventions recommended by the pharmacist were then categorized into one of 3 stewardship intervention groups. The first one was regimen, which looked at any changes in antibiotic choice, dose, or duration. Diagnostic was defined as recommending any additional cultures or testing. And then finally, counseling, which was defined as any additional patient education. The pharmacist would then directly communicate these recommendations to the provider and would document these recommendations within the electronic medical record. But ultimately, it was up to the provider to enter the orders based on the pharmacist's recommendations. When looking overall at the outpatient setting, this was defined as emergency department, primary care, and outpatient specialty clinics. And this is unique to this study because previous studies have mainly just focused on the emergency department and urgent care. Patients were then included if they were 18 years of age or older, had at least one outpatient antibiotic prescribed, and there also had to be a culture ordered in relation to that antibiotic. Patients were then excluded if they were admitted immediately following their antibiotic order. The primary outcome of this study was comparing accepted versus rejected interventions on 4 patient outcomes, which were 30-day all-cause mortality, 30-day representation rates, which was defined as a patient representing to an outpatient location for additional antibiotics, It also included 30-day admission rates and 30-day treatment failure, and that was defined as a composite of a patient representing to an outpatient location or admitted within 30 days for additional antibiotic therapy. This study also evaluated rates of appropriate antibiotics based on culture, location, as well as type of culture. And then finally, the study looked at the number and types of interventions made. Here are 4 definitions that we will be using in the following slides. The first is drug-bug mismatch, and this was defined as discordance between antibiotic and culture susceptibility report. It was also defined as cases of bacteria with known resistance to the prescribed antibiotic, or it could be defined as a negative culture without growth that was prescribed an antibiotic. Drug-bug match was then defined as concordance between prescribed antibiotic therapy with the culture susceptibility report. An accepted intervention is when a pharmacist made a recommendation and this was acted upon by the provider. And a rejected intervention was when the pharmacist made a recommendation, but this was declined by the provider. This study used descriptive statistics and a bivariate analysis to compare outcomes in patients with accepted versus rejected interventions, and this was appropriate for this study. Overall, there was 7,360 outpatient antibiotics ordered. Of those antibiotics, 965 were ordered in relation to cultures, which excluded slightly over 6,000 antibiotics. And in the future, this could be an area for more research, because if these antibiotics were reviewed, would we potentially see antibiotics without a clear indication and be able to provide further intervention? Of the 965 that were ordered and had a culture as well, a pharmacist was able to make an intervention on 194 of those antibiotic orders. So the results of this study specifically focus on those 194 encounters that required an intervention through the culture review service. Of the 194 patient encounters, 148 had an accepted intervention, which was 76%, and the remaining had a rejected intervention, which was 46 or 24%. When looking at baseline demographics, patients were primarily older white males, and the most common location for antibiotics was the emergency department and the primary care setting. The most common indication for antibiotics was urinary tract infections. And when reviewing the literature and other previous studies, this is one of the most common indications for antibiotics in the outpatient setting. When looking at the most common antibiotic classes, this is beta-lactams and primarily 3rd generation cephalosporins, fluoroquinolones, specifically ciprofloxacin, as well as Bactrim. And when looking at these antibiotics, this makes sense based on the most common indications, because these therapies can be used to treat these infections in specific patient scenarios. So when looking at specifically accepted interventions, the most common type of culture was either gram-negative or gram-positive. When looking at the rejected group, most commonly, we saw mixed cultures, which was a mix of both gram-negative and gram-positive, or it was a negative culture without growth that was prescribed an antibiotic. Overall, the majority of antibiotics were considered to be a drug-bug mismatch. And when looking at what the most common culture was in drug-bug mismatch, this was seen in gram-negative cultures. Then when comparing drug-bug mismatch to drug-bug match, mismatch occurred more commonly in mixed cultures and negative cultures without growth that did not require antibiotic therapy. Interventions were more likely to be accepted when antibiotic therapy was actually indicated. And when looking at the 3 different types of interventions, the most common was a recommendation and change in regimen. And when looking at the most common recommendation, this was a change in the actual antibiotic agent. So like I mentioned before, only a few studies have evaluated the impact of antimicrobial stewardship programs on patient outcomes. So this study specifically looked at 4 patient outcomes. So when looking at these outcomes, patients with an accepted intervention had a statistically significant reduction in 30-day treatment failure, as well as 30-day related admission. And mixed cultures were more likely to experience a 30-day treatment failure when the intervention was rejected rather than accepted. Although a fewer percentage of patients in the accepted intervention group had a reduction in 30-day representation or 30-day all-cause mortality, this was not shown to be statistically significant. Some limitations of this study were a smaller sample size. The next was this was based on chart review, so information was limited to what was documented in the electronic medical record. So if patients were admitted to outside locations or they received antibiotics from outside facilities, this was not potentially reflected in their results if it was not documented in their electronic medical record. This study was also unable to assess patient adherence. So although they were prescribed antibiotics, it's unknown if the patient was appropriately taking the therapy. And then finally, looking at external validity. So this was primarily an older white male population. And also the authors of this study did not provide a more detailed description of their protocol and culture review service. So it's more difficult to apply this to our own individual practices. However, I still believe this study highlights an important role pharmacists can have in antimicrobial stewardship. Looking at strengths of this study, so this is an important topic in the literature, and it included a variety of outpatient practices and expanded off of the emergency department and urgent care settings. This study used an appropriate analysis for their data, and they also included patient outcomes, which is unique to this study since there's been only a few previous studies that have looked at outcomes. And then finally, this study did show a similar percentage of inappropriate antibiotic use compared to what's been published thus far. So then how do we apply this to our own individual practices? So first, looking at the most common indication, this being urinary tract infections. And this is also similar to what's been shown in the literature so far. So as pharmacists, it's important to be familiar with current guideline recommendations for treatment. So knowing what is an appropriate first-line agent and appropriate duration of therapy, as well as when to treat. So looking at asymptomatic versus symptomatic UTIs. The biggest takeaway with antibiotic classes is to ensure that we're adequately covering for all pathogens while avoiding broad spectrum use unless clinically necessary. For location, although the most common location was in the emergency department, this study did have a portion of patients who received antibiotics from the primary care setting. And this demonstrates that there's an overall need for outpatient stewardship programs in outpatient locations. When looking at drug-bug mismatch, this was commonly seen with mixed cultures, so ensuring that all pathogens are covered for a patient's culture. So this could potentially mean escalating therapy when necessary. And then also the drug-bug mismatch was also seen with negative cultures, so making the recommendation to discontinue antibiotics when they're no longer warranted. And then finally, the majority of antibiotics requiring an intervention were actually indicated. And there's this negative connotation that antimicrobial stewardship equals stopping antibiotics. However, it's also making sure patients are on optimal therapy, which is further supported by the results of this study. So then how do we start and implement a stewardship program, and what are the steps? The CDC has recommendations for various practice settings on creating stewardship programs. So when we're specifically focusing on the outpatient setting, they have 3 recommended steps. The first is to identify a high priority condition for intervention in your setting. Some examples would be looking at antibiotics that are often overprescribed. For example, I'm using antibiotics for viral pharyngitis, or when the antibiotic may be appropriate, but the condition is improperly diagnosed. For example, treating strep throat and diagnosing strep throat without a throat culture. The second step is then identifying barriers that lead to deviations from best practices. And this could be gaps in knowledge about current guideline recommendations, but also there's this perception that patients expect antibiotics and that there's a pressure to prescribe them due to concerns about decreased patient satisfaction when antibiotics are not prescribed. And then finally, the third step is establishing standards for antibiotic prescribing. So this is using clinical practice guidelines as well as resistant patterns in order to establish clear expectations for appropriate antibiotic prescribing in order to hold all prescribers accountable to the same standard. So it's important to recognize that stewardship programs do not necessarily have to be these robust culture review services. This can be challenging without automatic reports within the electronic medical record and without adequate resources and pharmacists. Other stewardship programs can include educating on current guidelines and implementing algorithms within your practice in order to help guide treatment therapy decisions. Another study looked at having providers sign an agreement to vow to avoid the use of inappropriate antibiotics. And both of these strategies have shown to be effective and may potentially not require as many resources or be as challenging to implement. So overall, conclusions from this study illustrated an important role pharmacists can have through implementing programs within their health system in order to help reduce antimicrobial resistance, potentially decrease rates of treatment failure, and reduce hospital-related admissions, while overall improving the quality of care for patients. Here are some additional websites that provide more information and tools in order to create an outpatient antimicrobial stewardship program in your practice setting. And with that, I want to thank you for the opportunity to present today. And at this time, I will take any questions.
It looks like Lindsay had asked earlier when you were speaking about the majority of interventions coming from the ED. I know you mentioned in your kind of closing statements that each of the specialty clinics and primary care and ED all had interventions that were accepted. Was it a vast majority of these interventions that came from the ED, or was it pretty well distributed throughout the different practice settings?
That's a great question. So when looking at the breakdown, so the ED was the majority. However, primary care was not far behind. Looking at the specialty clinics specifically, this was a smaller percentage compared to the other two. So I would say is, applying these results for their culture review, I would say, it would be most applicable to the emergency department or primary care, just because we didn't see as many patients from the specialty care setting.
Great. Any other questions from anybody else? I did have a quick question, just how you kind of mentioned at the end, which was great, just talking about that, not everybody has all of the resources at their facility to dedicate a full FTE. But going forward, as you transition from a PGY2 to a new practitioner, do you see yourself, based on the results of this study, trying to implement any of these guidelines or policies at your new practice site?
Yeah, that's a great question. I think this is, definitely a hot topic in the literature, and I think it is something important and to take into consideration and to apply in my future practice. As far as will I be primarily in a stewardship role, I am not sure, but I think through our collaborative drug therapy management, whether we're managing diabetes or hypertension. When we're doing chart reviews for patients, I think, paying close attention if they do have antibiotics ordered and trying to make recommendations, or if there's a need within the specific primary care site that I will eventually be located at, seeing and trying to find reports of what is the most common antibiotics and indications seen at this practice, and is there an opportunity to provide recommendations on first line therapy. So whether it's actually creating a stewardship program, that would be awesome, but like I said before, it can be challenging. So I think in my future, just trying to provide that education can be helpful.
Yeah, great. Everyone can help be a steward for sure. Well, it looks like no other questions came through. I just want to say thank you both to AJ and Tamara. Excellent presentations today and helping all of us continue to grow our practice and help our patients and advocate for the best therapy for them. If there's no other questions on the floor, then we'll go ahead and log off, and I'll be sending the link out eventually through the PRN website and the listserv. So thank you again to everybody, presenters, mentors, and attendees.